So hello students, today we are going to discuss is something different, something about painless dentistry procedures, something about how to be a successful dentist, how to be a successful clinician. So this trick is must for each and every dentist, either performing a root canal procedure or extraction or day-to-day practice. When he fails to provide pain-free treatment to his patients. Well, I'm talking about how to give a profound mandibular anesthesia when the inferior alveolar nerve block fails. So this is what the examiner favorite question asked in the NEET entrance exam. So knowledge is power and you should know how and when to recharge your battery. So yes, today I shall be discussing about the Gow Gate nerve block. So first of all, you should know is who described the Gow Gates. Well, in the year 1973, George Albert Edward. So it was George Albert Edward who in 1973, first of all, described Gow Gates. He was a general practitioner, a general practitioner of the dentistry in Australia. So he was a, remember, general practitioner. So who described a new approach to the mandibular anesthesia. So what he did, he described a true mandibular nerve technique, a single anesthetic injection that provides hard and soft tissue anesthesia of the mandible to the midline. So what are the other name of Gow Gate technique that you have to remember for your exam? Number one, it is also known as Gow Gate technique or third. Remember, it is also known as third division nerve block or V3 nerve block. So what are the nerves that are anesthetized in the Gow Gates technique? Let us discuss that. The nerves that are anesthetized are the inferior alveolar nerve, mental nerve. The nerves that are anesthetized are inferior alveolar nerve, mental nerve, inferior alveolar nerve, mental nerve, incisive nerve, lingual nerve, mylohyoid nerve, buccal nerve, and auriculotemporal nerve. So remember, all these nerves are blocked with the single block. Also, buccal nerve is also anesthetized with this single block. So what are the areas that are anesthetized? Number one is the mandible teeth to the midline, buccal periosteum, and mucous membrane on the site of injection, anterior of tongue, and floor of the oral cavity, body of the mandible, inferior portion of the ramus, skin over zygoma, posterior part of cheek, and temporal region. Now, where Gow Gate should be indicated, where we should give the Gow Gate technique. So there are the Gow Gate technique. It is indicated when there are when we have to perform like we have to perform multiple procedure on the tooth. So while performing multiple procedures on the mandibular teeth, we give a single anesthesia that has power that will block all the nerves. So when we should give this block? When the buccal soft tissue anesthesia from the third molar to the midline is required. And why Gow Gates is must? When conventional inferior alveolar nerve block is unsuccessful. So in order to be a good clinician, you should know when to give Gow Gate block. So Gow Gate is required when the lingual soft tissue anesthesia is required and when conventional inferior alveolar nerve block is unsuccessful. A successful practitioner is one who delivers and provides painless dentistry to the patient. Have you ever tried Gow Gates in your day-to-day practice? Yes. Try to be successful dentist. Try again and again till you learn that technique. So it is the easy tip and trick to grow your practice. Now, what are the contraindications of this block? We generally see is patient who might bite their lip or tongue, such as young children and physically or mentally handicapped adults. Some people who are unable to open their mouth wide open. We don't give Gow Gates there. So in patient who are unable to open their teeth, what we should give is Vazirani Echinosis technique. So remember, for your exam, Vazirani Echinosis technique is given to those who are unable to open their mouth. Now, what are the advantages of this Gow Gate technique? The advantages are it requires only one injection. So one injection that will block all the nerves. So a buccal nerve block that is blocked unnecessary. Other, it has a minimum aspiration rate. It provides successful anesthesia in case when there are bifid inferior alveolar nerve and bifid mandibular canal. So this block is advantageous in that. What are the disadvantages? The disadvantages could be lingual and lower lip anesthesia that is uncomfortable for many of the patient. The time for onset of anesthesia is somewhat longer. That is 5 minutes than in inferior alveolar nerve block. Now, why we have to wait more in case of Gow Gates than the inferior alveolar nerve block? Why? Think. Yes, because of the size of the nerve trunk and the distance of nerve trunk from the deposition site is greater. So that is why we have to wait for another 5 to 10 minutes for block to get effective. Now let us discuss the technique. So what is the technique? The patient is placed in the supine region. The patient have to keep open mouth wide and remain in that position until the injection is completed. So what we have to remember is Gow Gate technique. Gow Gate technique require patient mouth to be wide open. Yes, that is true. And where we have to deposit the local anesthesia, we will deposit the local anesthesia anterior to the neck of condyle in proximity to mandibular branch of trigeminal nerve after it exists from the foramen ovale. As we know that the motor roots that joins the sensory root before leaving the skull through the foramen ovale. So the mandibular nerve, it descends from the foramen ovale, and the nerve position is little anterior to the neck of condyle here. So that is the region where we have to give the block. So the landmarks that we will use externally are the number one is the corner of the mouth. So this region, the corner of mouth, and to the intertracheal notch of the ear. So this region is the intertracheal notch. So what we will do is join this line. So that is the region where we will insert the needle and move it externally. So what we have to do is we palpate first of all the anterior border of ramus. Suppose this one is the anterior border of the ramus that is palpated. The tendon of the tendons of the temporalis muscle that is identified. So the operator visually aligns the intraoral and extraoral landmark and directs the target on line extended from the corner of the mouth to the intertracheal notch. So the needle should be advanced until the fovea region. So this region is the fovea region of the condylar neck is contacted. So remember the fovea, it is the insertion of the inferior belly of lateral pterygoid muscle. Very good. So depth of insertion that should not exceed 25 to 27 mm. So after that, what the operator will do, it will withdraw the needle. So little withdraw the needle, and the patient have to keep the mouth open for that second to allow the bathing of the nerve trunk. So that is here where we inject the local anesthesia. So what would you see the sign and symptom? That the sign and symptom that could be either subjective or objective. So the subjective signs would be, there would be tingling or numbness. There would be lower lip anesthesia due to the anesthesia of the which nerve? Mental nerve, a terminal branch of the inferior alveolar nerve. There will be anesthesia. There will be the numbness of the tongue. Why? Due to the anesthesia of the lingual nerve, that is branch of the posterior division of the mandibular nerve. Now, what are the objective signs that you will see that can be felt using the instrument? That is, no pain is felt during the dental therapy. Now, what the complication can occur due to the failure of anesthesia is hematoma, trismus, or temporary paralysis of the cranial nerve. So this was all about Gow Gates. I'll come up with Vazirani Echinosi closed mouth mandibular block. Again,